nerve. My principle has been if the aneurysm is compressing the nerve, oculomotor or optic nerve chiasm, then you should have direct surgery. And I saw these cases now. So this is a patient has oculomotor palsy on the right side. We have published also in 90s that the effective treatment is direct surgery, and you should do it within 1 week of the occurrence of the third nerve palsy. So then it always recovers. When you do it later, then it's not recovery. This is right-sided lateral supraorbital approach. I go below the globe, the right optic nerve, dissecting the sucking CSF out, so to get more space and to have the brain slack, sharp dissection of the arachnoid, and now we see the carotid artery, and this is beautiful. This carotid artery is not calcified, it's not atherosclerotic like many times in China, extremely heavy atherosclerosis calcifications, making temporary clips impossible. So just slowly making by sucking CSF out, making more space, and then we follow upwards the carotid artery. See, I'm not using retractors here, just making the brain slack. And now I'm dissecting on the carotid artery, and you see now under the schizos, you see the aneurysm, and directing a little bit laterally, posterolateral. This means that this aneurysm is able to compress the third nerve. Most common third nerve palsy are coming from PCAM aneurysms. Actually, next one is basilar superior cerebellar artery. And now comes the crucial point of surgery here. Put temporary clips, proximal, distal, below anterior choroid artery, and then the aneurysm is not yet slack because the PCAM is strong, it's filling the aneurysm, but I didn't want to put there because the space is little. So, but I study the situation. This is the dissector, has the same breadth and the bigger aneurysm clips, and now I push the first clip there carefully, and I see all the time the PCAM here. So it takes the aneurysm base, but not PCAM artery, very strong PCAM. That kind of PCAM you have to, you may not occlude. And the second clip is taking more of the base, and now the distal clip, temporary clip is coming out, and then the proximal one also. And then we check the situation. And there is ICG now. We see that the aneurysm is no more filling. There is a little bit base left, but we will correct that later. Now, what we are doing, we open the aneurysm, and this decompress third nerve. You should not make any resection of the aneurysm fundus here because it is attached to the third nerve, and you may make a lesion in the third nerve. And now a small clip is taking the remaining base of the aneurysm, and what we are checking now, we are still checking for the patency of the PCAM. Checking carefully, anterior choroid artery is patent, and then with Doppler checking once more the strong PCAM, good sound. Then this is postoperative CT, and patient made good recovery, and because the operation was early after occurrence of oculomotor palsy, total recovery very soon. Then we go to the next video. Number 1, 2. Then we take a big rather big aneurysms, 3 cases, giants, real giants. This is the second case, and video edited by Johan Sokua Velasquez. Tomorrow he has his PhD dissertation on pineal cysts and tumors in Helsinki. So here you see the CT angio, big aneurysm, strong aneurysm, looks terrible. So this is the lateral supraorbital approach, a little bit shaving. And then 1 layer opening, very fast opening. With this approach, in 10 minutes you are opening, or you have opened already the dura, and here we open the Sylvian fissure, so just to come above the aneurysm and to have control of the distal carotid artery. And here you do intradural anterior clinodectomy to have proximal control. Proximal control is in my surgeries done by putting temporary clips on intracavernous carotid artery, which is here. It's a good place, seldom as atherosclerosis. So you can put your temporary clips there, and then you have good temporary control. Other possibilities are, of course, balloon in carotid or rubber string around the carotid in the neck. I usually put 2 clips here so that I'm sure that they are taking the strong carotid. Now we have temporary clips around the carotid artery, and then we dissect distally, and we have to put temporary clip there also. And one more thing, coming from, we have to put also temporary clips there. And now cardiac arrest with adenosine, wait with the ring clip, first clip is ring clip, cardiac arrest, and then we put the ring clip in place, and with the help of this ring clip we can put the next clips in the place. They are going now, straight clip, and then taking the ring clip out, no, pushing it deeper because the aneurysm wall is calcified, so we need, for the strong aneurysm wall, we need strong clips beside each others, helping each others. And now you see that the aneurysm fundus is clipped, but base remains. So I take a longer clip to take all the base, and it needs some other tricks to take all the base. So temporary clips are still there. Long straight clip is going there, but above that still base remains. So now I take the temporary clips out for a while, study the situation. I think, yeah, I add more clips across the first, those long clips. I put more clips and ring clip across them so that the old former clips remain inside the ring. So this clip takes the remaining base, and then taking the temporary clips out very carefully, slowly, so that you can put them back if needed. And then adding papaverine here. And this is the situation. This is, of course, CT angio, a lot of artifacts, but you must see that the aneurysm is gone and the patient has made a good recovery. So we take the next slide. This is number 3. Okay, here, this is an older patient, more than 70 years old, had the visual disturbances, and we begin with the goal. So we are already down here. I take some muscle to put in after clinoidectomy, because sometimes ethmoidal cells are opened, so there might be CSF leak. Okay, I put this muscle there, and then we take a look on the dissection. So you see that this aneurysm is mainly thrombosed. I go with the knife inside, and of course now there is no return. So this is CUSA. I'm emptying the aneurysm as long it begins to bleed, and then I put the temporary clips on intracavernous carotid artery and distally on the carotid above the aneurysm. Now it bleeds, so I put the temporary clip on the intracavernous artery distally. It bleeds somehow, still coming from ophthalmic artery, maybe become that the bleeding is reasonable. Now and you see what happened. I fractured the base of the aneurysm. Terrible. You see there are big holes. Yeah, now you see beautifully. Terrible. So what to do in this situation? Fast thinking, fast thinking. I had the muscle piece there. I put the muscle there and clip this. Put clips which press muscle on the hole. Second clip to compress the muscle against the rupture which I made. I didn't think it is so fragile, and now we take the temporary clips out, only one in intracavernous segment here, and then make Doppler. Good sound, happy. Put one more clip there to compress the muscle in place. And this is ICG, and in spite of this terrible intraoperative complication, we could manage, and the patient recovered well in spite of high age. So, next one. This one, yes. It's a very giant carotid aneurysm, compression, and you see the huge aneurysm. So this is the operation. Patient is rather young. One layer craniotomy here, making it more pterional, so we get more the approach around the aneurysm. Now we see Sylvian Fischer is also involved in the opening, and then we go down. A1 is here. And now we dissect around the carotid. First, I didn't do clinoidectomy here because I thought I can manage with the temporary clips on the most proximal, and adenosine again. You see the heart was stopped, and then opening of the aneurysm. You cannot clip this aneurysm without opening and it bleeding. And then we take ring clips, L-shaped, D-shaped ring clips, and then put them around the carotid artery on the base of the aneurysm that is behind the carotid artery. Carefully, you cannot make it with one clip. You need more, a row of clips, and you have to be careful when putting them that no space is between the clips, otherwise the aneurysm will still fill, and as I open it with knife, so you have to have absolute good row of the clips. This is ITG. We see that one part of the aneurysm is still filling, so I think I made here a clinoidectomy and took all the clips out, and yeah, the clinoidectomy, partial clinoidectomy is coming, So I have the temporary clips now around intracavernous artery, and then replace all the clips. And then I have a good row of the clips, and this gives total occlusion of the aneurysm. Adding many clips now, I don't see clearly. The focus is not good here now in this video, but now it's coming better. Yes, and then checking, carefully checking. Adding more clips to take the remaining aneurysm part away. Long row of clips, and these are postoperative images. You remember it was huge aneurysm. Now it is many artifacts there, but the aneurysm is gone and the patient recovered well. Then I have the last video, shows that the long-term, down, this one, that the long-term follow-up is extremely important. This patient was young, lady or girl, 18 years, 2001 or 2, when I operated her small carotid bifurcation aneurysm. Beautifully, press, media was there, interviewing Professor Yasakin and also the patient after surgery. Everything went well, but 8 years later, the patient had headaches, and we make, oh, take the sound away. Sound away. Okay, so the patient had headaches, and we took her re-examination. You see now what happened. The clip is above the aneurysm, and there's a giant aneurysm in the place, and this is very difficult situation now in carotid bifurcation, especially because you cannot do any bypasses here, so you have to go directly to the aneurysm here, scarred carotid artery, scar around it. I put 2 temporary clips to have certainly, and then this is A1, so temporary clips there, and then we have also M1, so we need temporary clip there to have all the flow to this scarred giant aneurysm, very complex, dissecting around the aneurysm, then putting first clip according to Drake. Always put the ring clip first on the giant aneurysm because it is not slipping away because of the hole in the shaft. Carefully, and now dissecting again. A lot of scar. This is difficult now. One more clip added, and the old clip remains at the top of the aneurysm because we wanted to have a reference where we are. And then curved clip, take the part, saving the A1, but now still a lot of aneurysm remains. I think I removed the temporary clips to give a good flow for the brain, and then remove the temporary clips for a while, and then put again them to take the remaining part out. Now I'm dissecting without temporary clips, remaining aneurysm. I think I should put temporary clips again. Let's see what's my strategy here. Dissecting, so behind the carotid bifurcation. Again, temporary clips are going there. It's very difficult to clip giant aneurysm without temporary clips, but now only on carotid artery. And now I take a ring clip that leaves the carotid artery free, L-shaped, and takes the remaining giant aneurysm inside the clip. Clip closing slowly. And also intraoperative TSA, which is very important, otherwise you cannot think. Here you see that the aneurysm is gone. What is the worries? The patient will develop again a new aneurysm because there must be some kind of vasculopathy. So these were the 5 cases I wanted to show. Principle is that if you have a nerve compression, oculomotor nerve compression, or optic nerve compression, I think the open microsurgery in experienced hands gives the best solution and long time solution. Thank you very much.
Okay. Thank you very much, Professor Herner-Niemi. Thank you very much, all professor, all audience. I'm sorry, I just late my connection, a little bit late. Thank you, Juha. I think I have many questions for the audience. The last case is really the important case for the endovascular. What do you think is the origin of this? Is regrowing of aneurysms? What do you think about the origin of this?
If aneurysm recurs after perfect clipping or after perfect treatment, you should also think that there is some kind of vasculopathy. So you have to think that the patient will develop later. This was a young girl, 18 years, and a wonderful clipping in the best hands by Professor Yasakil and me in the operation, and perfect postoperative angios, no remnant, but she develops that kind of giant aneurysm. So this is seldom, but shows also the importance of long-term follow-up. If you tell that after 1 year it was okay, you should not say like that. You need 10 years follow-up to be sure about your treatment modality. It is seldom that aneurysms that are clipped recur. This is by far more seldom, but of course it happens. No one can say, in my hands, never recurred. I have heard that in lectures, but this is nonsense. Then you have no real follow-up. You have to be honest and tell all the complications.
Okay. Another question? Okay, so if you want now, Professor Lilik present their experience in flow diverter to treat the aneurysm. Dr. Lilik worked in Enery Center in Hospital Sagrada Familia in Buenos Aires. Is the best neurointerventional in Latin America, also around the world, because I have many cases. I have a good experience with the flow diverter in giant aneurysm cavernous senos. Pedro, are you here?
Yes. Good morning, everybody. Or good afternoon in Madrid. Good evening in China, probably. It's my pleasure to be with you guys.
Okay, whenever you want.
Okay. Let's share my screen. Hope you can see it. Let me see. Okay. Probably you can see it now. Those are my disclosures already. I will share our experience in our endovascular center in Buenos Aires. It's an international center for training. I would like to acknowledge to all my team, and especially all the fellows that I have everywhere, and especially to my fellow from China, Hongji. So we must focus on the patient, of course. We know that we have a beautiful options, surgeons. they develop fantastic options, as already shown by Professor Eresmini. We have some things to share with you from the endovascular point of view. I think the terms complex is exactly some that we need. Those are fusiform, dissecting, wide neck, blister-like, so are more than giant, really. So I define complex aneurysms, those that can be also large with exceptional wide necks. But for me, meaning complex is a high morbidity and mortality, and particularly difficult in management of those complex. We know the natural history of those as very severe. 80% of the patients with symptomatic giant will be invalid or dead in 5 years. So this is a complex situation, especially because not only the aneurysm is complex, but we're dealing with age, aortic arch, general condition like obesity, some associated pathology like dysplasia or carotid disease. If you have a look on multifactorial origin of the aneurysm, there are several things. Some are more important for us from the endovascular point of view, like internal condition, as you see here. We share with the microsurgery the condition of the walls, and I guess from microsurgery, probably the external conditions are more important. But as you have many different aneurysm patient, also you need different devices probably. So from the endovascular point of view, we have different devices for rupture or for unrupture. For rupture, we still favor coiling. For unrupture, we are most doing flow diversion. In Buenos Aires, we're still using coils, but as you see here, we more and more are using stent and flow diversion. We did our first stenting back in 1996 because we understand that we have to reconstruct the artery, trying to have circulatory exclusion for those aneurysms. So we start with coiling back in the 90s. We are doing more and more flow diversion, flow disruption for those aneurysms. And nowadays, we are having surface modification devices, as I will show you. Many devices on flow diversion. I will just show a couple of them. We are using that flow diversion to reconstruct segmental disease. What I mean by segmental disease? Well, is when I have a damage in the artery that involves more than a quarter of the vessel circumference or the same distance in length. We are doing some kind of flow modulation through the artery to the aneurysm. As we can modify fluids on the beautiful fountain, water fountain, we also can do the same thing with modifying some flow conditions intervascularly. So this is a 51-year lady with a headache with 4 aneurysms in a row. Please pay attention. The proximal one, the ophthalmic, arises from the base of the aneurysm. So what we are doing, if we implanted a flow diversion here, we make a channel inside due to the sum effect of the ophthalmic artery. You see 9 months after, the 3 aneurysms are completely occluded, but there is one which remains open. What will happen if you follow those, and I 100% agree with Professor Eresmini, we need to follow those patients. You see the progressive shrinking over the time, but the ophthalmic, it remains completely open. So we're remodeling the artery, but we keep the arteries open. So this is our beginning. And the second generation pipeline, long-term follow-up, 9 years showing the durability of those giant cavernous aneurysms. There's another case, 7 years follow-up, nice remodeling of the artery, as you can see, and the metal is durable. So we have an extensive experience with flow diversion, more than 1,700 patients treated. We know that we are safe, we are efficacious, and we have a long-term follow-up in most of those patients. What I mean by safety? Well, as was shown by PAF study, we are between 6 or 7% of morbid mortality. And most important, we are very efficacious, we had more than 90% of occlusion at 6 months and 1 year. So I think we learned a lot. We learned that we can treat the same patient with three complex aneurysms, both cavernous, one dissected in the right vert, were treated with three devices, as you can see there. And this is a 6-year follow-up showing again the durability of the method, which is sent to publication. Our experience, 13 years of pipeline, 1,000 aneurysms were treated. We using more than one pipeline, of course. The average 1.21. 1/3 of those, 35%, were large or giants. We call those complex. 84 of our series was circular itself, like those. But what happened with, if we count the mortality of that particular group of giant and complex, we have almost 3-fold mortality. That's why I call those really complex. We started at the beginning with the very proximal aneurysm at the level of the cavernous sinus, the ophthalmic segment, but we went on after and went and reached some distal examples. So this is the beginning, three of those cases, and after we went a little bit more distal. Regarding the ophthalmic segment, I think this is a case with a young lady, 50-year-old lady with complex aneurysm on the ophthalmic segment. This is pre-treatment 2D, and this is the way that it shrinks, 1 month, 6 months, and this is almost 4 years, showing again the remodeling, nice remodeling of the artery. This is another lady with a similar one with the right amaurosis already installed, and this is 2-year follow-up showing the remodeling of the artery. So what are our limitations? Because we have limitation on those giant and complex aneurysms. The main limitation is to find the exit. Sometimes we have to look 360 inside of the aneurysm to reach the exit. Sometimes we have to do a double loop, try to reach the MCA to anchor our guide wire all the way down. Sometimes we have to use balloon to straight up our guide wire inside of the and the microcatheter inside of the aneurysm. Or sometimes we have to anchor with a stent even. So this is another lady that she was blind from the right side. Was blind from the left side, but going blindness also in the right side. You see the mass effect. Everything was compressed on the left. There was no blood coming from that side due to this giant hypophyseal aneurysm. So this is the fusion overimpulsion with MRI and DSA in one single screen. So it was very difficult to manage. I tried everything. I tried the septal, proximal. I couldn't pass and find the exit. Finally, I succeed with 2 wires. I put the first wire very distal on the left MCA, and the second wire was the ACA. So using that, I tracked my Marksman catheter at that time, and I was able to construct three telescopic pipeline from distal to proximal. As you can see there, this is the immediate result with some vasospasms on the left, on the right MCA, but then it was occluded. This is as soon as I released the catheter, everything was okay there. So this is 4 months follow-up. You see how diminished the mass effect on the left. This is 1 year follow-up showing the reconstruction of the artery. So this is another little bit more distal with a severe mass effect. You can see the MRI, the two axial view, flare axial also. This is immediately 1 year follow-up showing the shrinkage and the release of the mass effect of this aneurysm. DSA and 3D showing before and after the complete remodeling of the artery. And this is again showing how nice we release the mass effect. She was a ballerina actually on the ballet on the classic ballet in Buenos Aires. A little bit more distal and anterior, again with the giant severe mass effect, as you can see here, better seen in the probably in the sagittal view, severe mass effect. So I bridge from A1 on the right to A2 on the left with one single device. She has already a left amaurosis, of course, was giant partial thrombus. So you will see the release of the same effect, and also the occlusion of the aneurysm. Please pay attention how we change the geometry of the artery over the time. And this is again almost 3 years follow-up, showing nice remodeling of the artery that was confirmed on cross-sectional image. I always do cross-sectional image on those either by CT or most frequent by MRI. So I trying to illustrate the limitation. The access and the exit are one. Sometimes the shortening of the device, if we unsheath too much our devices, there is a shortening, and you have a bridge disruption, as I will show you. You see, you unsheath too much, you must pull and push, try to really compress nicely the device against the wall of the, and you need more than one device, clearly. You need 2 or 3 sometimes. If not, you will have that kind of problem. So I was very happy here. I make a construction from the MCA all the way down. I put four devices. I try to accommodate between the bridge between the second and the third, and unfortunately, I rupture my construction. So what you can do in that setting, I was able to insert an alligator and pull the distal 2 inside of the aneurysm. I can show you that way. Those are the distal 2, and I was able to reconstruct again from the ACA all the way to the MCA. So this is before, and this is after showing the release of the mass effect in only 1 year, and the same thing you will see on DSA and 2D. Another limitation that we have, and I think we have to comment that, and we already published that, is if you have a stent that was previously implanted, you can have an endoleak, because the braided stent or the laser cut stent, sometimes it didn't oppose nicely against the wall. So if you're thinking to put a device in device, please pay attention and follow carefully those patients. And of course, we have complication. We have complication. I'll show you a couple of severe. The first complication that you can have is a bleeding after you insert the flow diverter. You can have a hyperacute bleeding, and those are mostly related to the wall injury by dissection. I will show you one case, because you elevate suddenly the gradient inside of the area. But you can have acute bleeding due to mechanical manipulation with guide wires and catheters. Subacute, you start to getting now the breakdown, the clot breakdown, and some cytokines inside of the clot. And of course, we had also chronic one until 1 month due to the inflammatory reaction inside that. On top of that, you have a patient with severe antiaggregation. So this is one of the hyperacute bleeding that I would like to show you. She was a lady with that giant complex ophthalmic aneurysm. As you can see there, I was able to insert one device, nicely seen on Combine CT and any single plane. We were very happy, so we decided to do the last run before we finished the procedure and send the patient to ICU. Suddenly you see the bleeding that occurs during the last angiography. The bleeding comes from the posterior part of the aneurysm, as you can see there. So this was my first bleeding. We published that back in 2011, an AGNR. We thought that was related mostly to the change of geometry to increase of pressure. But why those aneurysms bled after flow diversion delivery? Well, there are 2 mechanisms that's proposed by A.J. Wakalu. I think one are the hemodynamic mechanisms, and the second is the intra-aneurysmal thrombosis created by flow reduction. We release inflammatory markers, cytokines, and we can break down the wall. I think this is important. What we can do to help in that situation? Well, we try everything, believe me. We add some coils. We have more than one flow diverter. Sometimes I deliver even 5 flow diverters. But I think the questions that we have to keep in control, the blood pressure of the patient is very important, and do our best antiplatelet test. I think this is very important. This is very unusual situation, less than 1% of the patient, but what happened is very unfortunately for the patient is 100%. So I think the pre-treatment planning is very important for flow diverter. Have a look on the patient, what kind of animals you have, but also what device are you going to use. And don't remember, you must follow up those patients. The control of blood pressure for us is very important, not only in the ICU, but also when the patient went out of the clinic. The steroid, just a comment of the steroid therapy, I think are important. If the patient has symptoms prior to the treatment, we have steroids for 1 month. If the patient worsens symptoms after we placing flow diverter, we have soluble pulse 3 or 5 days, and after we keep the patient on steroids for 1 month. I think the wall enhancement is something special. We pay a lot of attention. Has been shown that the steroids decrease, as you see, the inflammation of the wall. So we keep a lot of an eye on that. If we have inflammatory reaction, we add coils or put more flow diverters. If we don't have inflammatory reaction prior to the treatment, we just insert flow diverter. I think for us, antiplatelets are very important. We are using prasugrel since 5 years now. We're loading the patients a week before with 60 milligrams. We are using it's very rare, seldom ticagrelor. When we treat patients in acute, we have to anti-aggregate them. We are using tirofiban or agrastat. What we learned? We learned that we need something new. We need really some kind of technology. We have surface treatment. So shield technology is the first one that came now 3 years. We are using in Buenos Aires. It's a Medtronic device, and HPC is another coating, comes from Phenox. The aiming try to have less platelets, as you hear here, few platelets in HPC too. So blocks early thrombocyte addition on devices. Very. I have done a couple of cases only with a monoantiagreration. I still using dual antiplatelation, but in some bleedings, I did use aspirin. Please pay attention that there are multiple medical interaction with aspirin if you are using like a monoaggregation. The stress, the fever, and a lot of medication can, especially the ibuprofen and metamizole, can do really a problem for you. This is one of the cases that they did only with aspirin. As a dissecting A1 aneurysm, I implanted the shunt before we treat endovascularly. So that's the shunt was already implanted. I was able to put a very small, it's called P48. This is immediately after, and this is follow up 9 months. You see very nice reconstruction, and it's keeping 18 months now. And the patient is okay. Another bad complication that I would like to share with you is we were very happy at the beginning, but ended very, very badly. This is a 45-year-old male drug abuser. He already got the visual loss due to the right giant ophthalmic aneurysm. So it was very difficult to cross and find the exit. We did it finally. We implant first the enterprise like a bridge, a long enterprise, and inside of the enterprise we bridge with a long pipeline, as you can see there. So that was nice, a lip sign. We were very happy with the results. The aneurysm really shows that it was completely was completely occluded. So we did the 1 year follow-up. Everything looks great. The patient decided by himself stop the prasugrel, keep himself only on aspirin, and did a big party. And the party with drugs and whatsoever, he did a dissection on the right artery, did a stroke, and this is the way that he came to us the next day of the same day of the stroke, actually. So we crossed with a microcatheter. We were able to reopen the device with tirofiban, with the intra-arterial tirofiban. Here is 5 minutes, 10 and 15 minutes showing how we open the circulation. But at that time, we did a big mistake because we saw some clots. We were out of the doses of tirofiban, so we decided just to inject intra-arterial 10 milligrams of RTPI to clean those clots at that level. And of course, we cleaned the clots, but the aneurysm bled, as you can see here, start bleeding from the thrombus that was previously inside of the aneurysm. So we finished badly with that case, with that complication. So we still 13 years after, we don't understand clearly the healing mechanism and the thrombosis inside of the aneurysm. I think we have to work on that. We have to speed up our endothelialization. This is important. Not only have a nice monoantiagreation, but especially we need to increase the speed of the endothelialization. So in conclusion, I think the giant and complex are very challenging for both of us. We have risk and complication, as I showed you already. I think the therapeutic approach of deletion requires really a nice understanding because they have a unique anatomy and also some hemodynamic feature. So I think numerous challenging issues remain to be solved in the treatment of those complex intracranial aneurysms. I believe that we did our best effort, and I hope I finish on time. We will be having this topic in our next national minute. You are cordially invited, and thank you for your attention.
Thank you, Pedro. Thank you very much for your fantastic presentation. Any comments? Any comment or to the case of Pedro Lilik in the audience?
Excuse me. May I?
Okay, Dr. Bai.
Okay. Yeah. Dear Professor Lilik, thanks for your excellent lecture and very brilliant PPT. I have two questions about the technical nuances. One is, as we know, many patients with giant intracranial aneurysm combined with parent artery stenosis, especially somewhere adjacent to aneurysm neck. So what time and how you deal with targeting at the stenosis. The second question is, I learned a lot from your experience of flow diverter use in anterior circulation. Excuse me? Any experience of flow diverter use in posterior circulation? Thank you.
Well, yes, thank you very much for your questions. Really, I appreciate that. We see, as you pointed out, we see frequently stenosis, either proximal, sometimes even distal. I think this is due to the flow. I mean, the hemodynamics and the flow really impacts, and there is some hyperplasia there, probably. You know, I was very, at the beginning, in my experience, I was very prone to use balloons and try to fix that. After we implanted the device, I always try to fix that stenosis. until I had my second bleeding, actually. When we had the second bleeding, we sent all the information for the CFD. And it turned out that when we opened that stenosis, we increased the resistance distally, and we increased the flow. And there are some papers now by Juan Sebral on CFD and George Mason University showing there is some reverse of distal flow that can explain some of the bleedings that we have in those cases. So today, if I see the stenosis, I will not try to open 100%. If this is a very tight stenosis, I just underdilate a bit with balloon, but I am not going for 100% of dilatation because that can be a big problem. Regarding the second questions, we have most of the 80% of our series are anterior circulation, most, of course, more proximal than distal. But we do have experience in the posterior circulation and reconstruction the posterior circulation. I must tell you that it works better in dissecting aneurysm. It didn't work very nicely on those fusiform ectatic, dolic ectatic aneurysm because, you know, usually it's very late. The patient comes with 9, 10, 11, 12 nerves to our help, and we can help very much on those cases. But in the dissecting aneurysm and the sacral aneurysm, yes, we do have experience, and we have a good experience on that. I didn't show because, you know, we were very constrained to the anterior circulation, but we have experience, yes, in posterior circulation.
Okay, excuse me, Mohammed Helmi has a question. Doctor, I'd like to know your endovascular management strategy for CBS patients with a critical clinical condition.
Sorry?
Okay, I'd like to know your endovascular management strategy for CBS patients with critical clinical condition.
Well, yes, we usually, most of this series are unruptured aneurysm. We were very conservative for acute bleedings on the use of flow diverter. For the acute bleedings, we are using more, of course, coiling and balloon assistant technology. For unruptured, we are using, as I pointed out at the beginning of the talk, for rupture, it's clear that we are still using coils and especially balloon assisting coils. But we did some very ill patients especially with blister-like aneurysm. So for blister-like aneurysm with severe bleeding that we treat on day 2, on day 3, sometimes we use a monoaggregation in very selected cases with coated with coated flow diverter, either by Medtronic like a Shield or HPC. We use the question that you have to manage very carefully. If we use only aspirin, you have to use sometimes 3 times the doses, the normal doses, because some of those patients has fever. If you use only 500 milligrams IV, you will not have really a nice anti-aggregation. So for those cases, we are using either Shield or HPC.
Okay, Louis.
Okay, one question, Pedro. When do you like to place inside the sac the coil previous to deploy the flow diverter?
Well, this is a tough question, as you know. As you saw, many of those cases that I did, I haven't used coils because I really thought that we have to reconstruct the artery. But after the bleeding, the first and the second bleeding that we have, we start to use it. When I'm using now, what I see wall enhancement on MRI. We're doing always we do MRI before we do our cases. When we have a wall enhancement, that means we have inflammatory reaction at the level of the wall, we add some coils. How many coils? Well, we have bleeding even with coils. I try to put coils. I am not packed very densely, because if I pack very densely, I can increase the mass effect, as you know. So there's a compromise between using coils or not using coils. But generally speaking, I am still convinced that we need to reconstruct the artery without coils. But because we had those complications when we have inflammatory markers, we use coils, Luis. Probably is also your experience.
Okay, thank you, Pedro. I think now the next presentation.
May I ask one question?
Okay, okay. Sorry.
How are you organizing your follow-up study? This is certainly always difficult in the bigger countries. In Finland, we could manage very well, but I know after traveling around the world, in Latin America, USA, China, Russia, it is very difficult to organize the follow-up, 100% of all the patients. Please tell me about the follow-up.
Yes, Professor, it's an honor that answer your question for me. So it's, as you said, it's difficult, but for us it's mandatory. You know, all those new techniques has to have follow-ups. I mean, you know, the durability of the new techniques are always a question. So we have to show our follow-ups. At the beginning, our follow-up was 3 months, 6 months, 9 months, and a year. Our ethics committee asked for that. So now we are using 1 year follow-up and do yearly until 5 years. For those patients that reach more than 5 years, 10 years, we do again at 10 years. But I must tell you that today we are using more and more MRA rather than DSA. But the follow-up, as you mentioned, as you pointed out, and I learned from you also, it is very important. Even in Latin America, we need, when we do the consent of the patient, we try to point that very clearly to the patient and the family, that we need the follow-up of those patients. And of course, it's difficult everywhere, and it's difficult also in Latin America, and especially in Argentina, due to the several reasons. So sometimes the patient comes to us from more than 2,000, 3,000 kilometers, or from another country. But we were able to manage that nicely. I think the follow-up is something essential for everybody, and for us, because every time we have new tools, new devices, new develops, we have to prove the durability of the treatment, as you know. Thank you for the question.
Thank you.
Okay, Luis.
Okay, next presentation is for Professor Bin Su from Shanghai, and let's present the bypass in the giant carotid aneurysm.
Okay, Luis, thank you. So my presentation is a bypass for giant ICA aneurysms. So intracranial giant and complicated aneurysms, if you use a bypass, it's a blood flow replacement procedure, normally ECIC bypass. Around 80% was treated by flow diverters, just like Professor Lilik showed. Use pipeline and some Chinese-made tube bridge or silk. Sometimes, if it's cavernous sinus ICA aneurysm, we also can use a covered stent. So now less and less cases need a bypass. In our unit, now it's only around 20 cases per year. So bypass is a hemodynamic treatment for ICA aneurysms. Normally, it would combine with the trapping of the ICA or proximal direct occlusion of ICA. Sometimes we combine with the progressive proximal occlusion of ICA. The purpose is to decrease the pressure of aneurysm wall and keep the blood flow in perforators and keeps the blood flow of the distal parent artery. So before making the surgical plan, we should make the 30 minutes balloon occlusion test. In our unit, because we're doing both the open surgery and the interventional treatment, so we perform the balloon occlusion test by ourselves. If the patient can tolerate the balloon occlusion test very well, we will perform the enhanced balloon occlusion test, which means decrease the blood pressure around 30%. If still negative, this kind of ICA can sacrifice immediately and wouldn't cause any ischemic condition. But if it's if the patient couldn't tolerate the enhanced balloon occlusion test, we still need the bypass. Normally, the double bypass of STA-MCA is enough. If the patient balloon occlusion test was positive, we should make the plan of blood flow replacement. If the ICA only fitted the ipsilateral MCA territory, the patient is male, STA is larger than 1.2 millimeter. So the double STA-MCA bypass would be enough. If the patient is a female patient, normally the STA is quite thin, and this kind of condition, we should use radial artery to MCA. If the ICA not only feeded the ipsilateral MCA, but also the ACA territory, so this kind of condition, no matter the gender of the patient, ECA, radial artery, to sometimes combined with STA-MCA double bypass was needed. And if the patient, it's a predominant ICA, which means the ICA not only feeded the whole hemisphere, but also the contralateral ACA territory. So this kind of condition, we will use saphenous vein. This is type 1 ICA proximal giant aneurysm. Like this patient, the patient suffered right hemiplegia for 3 months ago. So it's a giant extracranial ICA aneurysm. And the radiologist tried to put some fluid diverter, but they failed. So then they transferred the patient to us. Before the surgery, we do the balloon occlusion test. The patient couldn't tolerate. So we use a bypass for the patient. So this is our most simplified technique of bypass. This is a loop technique. So the bypass procedure is quite fast. Normally, only take less than 10 minutes. So the occlusion time of the parent artery is quite short. And this is a real video. This is a radial artery to the MCA. So this vessel wall was quite thick, and it's quite easy to perform the anastomosis. So this is after this double bypass of STA-MCA, we can see the all patent. They are all patent. This is ICG. And after the STA-MCA double bypass, we performed the. This is I designed this progressive clip. So this is after the STA-MCA double bypass combined with the proximal ICA progressive clip. And in 7 days, we totally clipped the ICA. Then we performed the angiogram. We can see the STA was enlarged a lot, and the MCA territory was fed by the STA. So this is the ICA, ACAM and PCAM was also enlarged. So the patient was quite well. So this is type 2 ICA aneurysm. There's no collateral blood flow from ACAM and PCAM. So the blood flow replacement should cover the MCA and the ACA territory. So balloon occlusion test was strongly positive. So I use ECA saphenous vein to MCA bypass, and because the bypass blood flow was quite enough for feed the whole hemisphere, so we performed the direct ICA ligation. So this is type 3 ICA aneurysm. Poor collateral A1 and PCAM. The blood flow replacement should cover left MCA territory. So this is a balloon occlusion test. We can see the left A1 was quite small, and the PCAM was also very small. So this is a female patient. The STA was quite thin, so we use left ECA to radial artery to MCA bypass and the progressive ICA occlusion. So after the bypass, we performed the angiogram immediately and sacrificed the ICA directly. So this is an intraoperative positive of the radial artery. So this is the anastomose procedure. The ECA radial artery to MCA. So this is the last stage of this stoma. So this is a type 4 ICA aneurysm. It's a quite distal one. So the ACAM and the PCAM was quite good, but the 20 minutes balloon occlusion test was negative. But the 30 minutes is positive. So the blood flow replacement should only cover partial MCA. That's enough. So this is a young boy, and the STA was quite thick. So I just performed the STA-MCA double bypass and the progressively occlusion of ICA. So after 7 days, we can see the STA double bypass was all patent and covered the partially MCA territory, then sacrifice the ICA directly. So this is the final result. So type 5 ICA aneurysm with cavernous sinus syndrome balloon occlusion test was quite good, but the patient couldn't tolerate the blood pressure decrease. So this kind of patient only needs some low flow bypass. I performed the STA-MCA double bypass and then performed the ICA coiling directly to sacrifice the ICA. So you can see after the double bypass, the STA covered the partial MCA territory. So this is for some recurrent aneurysm after embolization. We just treated this patient last week. So you can see the patient suffered from hemorrhage, and they did the craniotomy for the patient in the acute stage, then performed the thrombus of the aneurysm. But after 2 years later, the aneurysm was recurrent. So this is our surgical plan: ECA to radial artery to M3 bypass, combined with the staged occlusion of right ICA. So this is a video. This is a balloon occlusion test. So we use formal incision, and this is a radial artery. Methylene blue, and this is a lot of scars because this is a post-operative case. So I use this M2 segment. So this is an anastomose procedure of the radial artery to MCA. So the MCA, the recipient artery was quite deep, and so I still use the 10-0 proline suture because the needle is quite small. So after the intracranial stoma finished, then perform the ECA radial artery bypass. So this is still intracranial. So this is a ECA to radial artery bypass stoma. Because this space is much larger than the intracranial, so I use a 9-0 suture. So you see the vessel wall was quite thick. So after finish the stoma, So then we can see the blood flow was quite patent. And this is ICG. You can see the blood flow come to the intracranium. And then I put the progressively clip, partially clip the ICA. And use MEP-SEP monitoring. So this is a picture, intracranial picture. Oh, sorry. So this is my take-home message, tailored bypass for ICA aneurysm, estimate the natural collateral blood flow, then make the right surgical plan to guarantee enough blood flow replacement. Thank you.
Thank you, Professor Bean. Any question to the audience or comments?
Quiet today, Louis.
Yeah, no. Professor Bean, when you chose the high flow bypass, and not to use the small temporal superficial bypass, where is the key point?
This patient, because they already did the craniotomy at the acute stage of hemorrhage, so they already cut the radial artery. STA, not the radial artery. So the radial artery was only donor artery for the patient.
But why not to use temporal anastomosis, temporal superficial anastomosis, and every time to use the radial anastomosis? Why?
You mean STA?
Yes.
Yeah, I told you that in this case, the STA was already cut at the first operation, the decompression operation when they removed the hematoma.
And the torque, your clip torque to progressive close the carotid artery is to still open more high flow in the anastomosis.
Yes, because this is a radial artery. This patient, actually, when you do the bypass, actually, the blood flow was not enough for totally replace ICA directly. So we use a progressive clip to occlude the ICA in 7 days. So in this 7 days, the radial artery can be expanded and the blood flow can increase until can achieve the total replacement of the ICA blood flow.
Very interesting.
Yeah.
Okay. Another question, another comment?
It's interesting that you have own device for the carotid occlusion. When I was resident, we used to occlude carotid artery progressively with Crutchfield or Sheldon device. What's the advantage of this one? Of course, they are no more in use, so you had to make a new device. But you know those old devices, Crutchfield and Sheldon.
Yes, yes, we also use it.
Widely used in earlier times.
I just made this progressive clip last year, and we used it in several cases, and it's quite simple, much simpler than the former ones.
Okay.
Next presentation, Dr. Bai from Henan Hospital. Is the neurointerventional from a group from Professor Hernaniemi. Okay, Professor Bai, thank you very much.
Okay. Okay, can you see my screen?
Yes, you want to make it bigger?
Okay, thank you.
Yeah.
Okay, and dear professors.
There we go.
Good
Yeah,
evening.
perfect.
Okay. Yeah. It's my honor to give my brief introduction of my experience regarding the flow diverter use for giant carotid aneurysm. I'm a neurointervention radiologist as a team member in from Professor Hernaniemi. Yes, in our hospital, the perspective for the aneurysm treatment is shift from the coiling packing to a flow diverter. So I know this topic is just focused on giant aneurysm. So I only introduce for giant aneurysm. In China today, we have some options to choose, including the most commonly used flow diverter, the pipeline, and our homemade flow diverters. We named it TubeBridge, which is kind of braided stent made in Shanghai. So the other type of flow diverter, Fred or Surpass or Silk, are not available in China today. So the following is the time point of flow diverter use in our hospital. So from the 2013, we had the first case of the flow diverter. We used the TubeBridge to treat a giant aneurysm. Till last year, October, the total more than 62 cases were treated by flow diverter. So including all types of aneurysm. Among which 212 are PED, and the other 15 are TubeBridge. So this table is a demographic features of flow diverter treatment in our hospital. You can say among of these more than 200 cases, is only 44 cases with giant aneurysm, with the bigger size aneurysm. So the flow diverter efficacy and safety for intracranial giant aneurysm for us is still limited. I have known the statistics in the subgroup of intracranial giant aneurysm. So the follow-up database is referring to general aneurysm population. So in the patients treated with flow diverter, we have a imaging follow-up, 3 to 31 months with median follow-up time 6 months. So the total occlusion rate is up to 72.2%. I believe with time going forward, the occlusion rate will be further improving. So we have to say the complication. So in our hospital, the morbidity and mortality rate is 1.9, including delayed rupture and death in 1, and cerebral ischemia and permanent deficits in 2, brain parenchymal hemorrhage and death in 1, and delayed parental arterial occlusion in 1. So as for gross complication rate is 6.49%, among which 13 cases was found in, okay, excuse me, why? What happened?
Don't know. Yeah, start sharing again. You fell off the screen share. Okay.
Excuse me.
There you go. It's full screen.
Okay, thank you. Yeah.
Full screen.
So as for long-term follow-up, with median follow-up time is up to 16 months. We have we found 4 cases with complication, hemorrhagic event and ischemic event in 2 cases respectively. So this is the landmark multi-central prospective clinical research, just as Professor Lilink said. So it's a very well-known clinical trial. In this trial, the big size and the giant aneurysm were enrolled. So as a result, is quite satisfying. So as for the technical success rate is up to 99%, and a majority of this cohort achieved imaging follow-up. As for the occlusion rate, when 1 year and a half is up to, it is more than 70%. With 1 year is nearly up to 90%. This is this result inspires us is quite promising. So as for the experience in our hospital, I give an example. Here is a giant aneurysm. I deployed a flow diverter and combined with some coils, just loose packing. 3 months post the procedure, revealed a majority of the sac are thrombosed. Just a small area adjacent to the neck remained open. Oh, you can see this giant aneurysm with flow diverter and a coiling and get a good outcome. So we have many cases to show the nice efficacy of the flow diverter. You can see this partially thrombosed aneurysm with coiling and the flow diverter deployment get a very good angiographic outcome. So as for the occlusion rate and occurrence, so from above the clinical trial is quite satisfying. And from the follow-up, you can see with time going, the occlusion rate is improving further. Okay, let me show some complication with live cases. So this is a giant aneurysm. Here is round-like structure. We performed a not bad curling and flow diverter deployment. However, a couple of hours later, the patient presented with is a severe headache. The CT scan revealed hemorrhage, and after that, we performed a recheck of angiography. We can see some clothes was packed to the dome. Some part of the aneurysm neck reopened. Okay, this is yes, the last case eventually passing away. So this case is a giant aneurysm with flow diverter with not a bad outcome with a follow-up 4 months post the procedure. We extend the flow diverter use to some other type of aneurysm, like you say. It looks like not a difficult case, but after the procedure, the patient suffered from parenchyma hematoma. We don't know why, but after that we performed decompression and evacuating the hematoma, and stopped the medication of antiplatelet using, and eventually the patient got a well recovery. It's not a severe deficit. So as for the hemorrhage post-flow diverter deployment, the possible reason, including the following from the literature, most of the reasons are just discussed by Professor Lilik. The one is maybe the hemorrhage might be injury caused by the catheter or guide wire, or after the flow diverter, some hemodynamic alteration happens, or the aneurysm wall has some inflammatory reaction. For some cases, we speculate cerebral infarction and a subsequent hemorrhagic transformation. In addition, some reasons are hypertension associated or some antithrombus medication associated hemorrhage may be deserve our more attention. So apart from the hemorrhage post the flow diverter, the ischemic complication we found as well. One is this one is the instant thrombosis. Even the patient after the procedure underwent a regular aggressive antiplatelet medication, there is still possibility to develop the instant thrombosis. Just like this one, he developed the occlusion of the parent artery 6 months of the procedure and get a stroke. For this young patient, we got a standalone flow diverter. So the aneurysm is closed. However, the follow-up imaging showed us instant stenosis, very severe, but asymptomatic. We didn't know the exact reason. So to summarize my presentation, the flow diverter seems to be feasible for giant intracranial aneurysm, but we do realize a learning curve exists. With our experience accumulated, less complication can be found. And for flow diverter is a big difference from other types of stent. The accurate measurement of the parent vessel and the flow diverter specification is very, very crucial, because the flow diverter deployment requires a very good vessel wall apposition. Otherwise, it would result in reoccurrence of the aneurysm or thrombus formation. Meanwhile, in some kinds of influences on the perforators and the branches should be noticed. Combined coil use seems to be helpful, even especially for aneurysm is a large sac and inflammatory aneurysmal wall. Last, modified peri-procedural management should be done, especially in this case. Thank you for attention.
Thank you very much, Professor Bai. Okay.
Thank you.
John, I'd like to present now and the discussion in the final, I think. John?
What's that?
Now my presentation and final the discussion. Is okay?
Yes.
Okay. I open this. Ok, compartir. Okay.
Perfect.
I'd like to present some case and also the history to the treatment of this type of giant carotid aneurysm. The flow diverter, Professor Lilik and Dr. Bai, Professor Bai present many cases with very good solution examples, but sometimes with a complication. In our experience, in the big size or giant aneurysm, I put the coils, I place the coils inside the sac before the stent because you are less surface to thrombus, and you are better disposition of the flow diverter inside the sac. The only problem is the money. But in this case, in lateral view, you are many times the flow diverter now open well. And the technique of many doctors is push and pull, push and pull. I think in my experience, this technique is not sometimes is not good. I prefer to deploy the stent quickly and at the same time to move the guide wire. No push and pull, you deploy quickly. Before they deploy the stent, I put the coiling. This quantity of coiling, no pull, many coils. And then you see the stent lateral view. It's a good. You have the catheter distal part to prevent any incident. AP view. After deploying the flow diverter, every time I place a balloon to angioplastia in the proximal part of the stent. But in this case, you are very careful because it's not open in this part, the stent. Look, and this is the origin of thrombus. This is the reason I need to place a second flow diverter or second stent to open well this part, the proximal part of the flow diverter. After second stent, and you are totally good result. One example of complication, delayed complication, is I present in another session, is Church-Strauss syndrome by bilateral giant aneurysm and delay complication. Church-Strauss syndrome is a systemic vasculitic associated with eosinophilis. It's treated by flow diverter, but also at the beginning is treated with a Leo stent in another center. This is the right carotid artery, and this is the left carotid artery. The right carotid artery is treated in June 2010 with Leo stent. This is the right. After, this is the left. He come in our hospital to treat the left side. And look, you are many stenosis, you are thrombus and stenosis before and the aneurysm and kinking and in distal part. 3D reconstruction, axial view, and AP view. This is the right with the Leo stent treated in another certain, and this is the left when I place one pipeline, but I have a problem to open the distal part. No, in this part, it's okay. This is the control after this stent, and this is the control few months later in the left carotid. You are a good result. In this time, 6 months later, I decided to treat it the right carotid artery. This carotid have a Leo stent. This is lateral view. You have some turbulence inside the sac. Before to treat, I perform the angioplasty in this part. And also, I place one stent. No, this is before angioplasty with balloon. This is before angioplasty, and this is after angioplasty. Still a small dilatation. In this moment, it's possible to navigate with a second catheter to deploy the stent. When this is lateral oblique projection, this is the flow diverter in the left side, this is the new flow diverter in the right carotid. I have a failure to open the papilline in this part. It's not open, never. I decide to turn with Terumo G, many torque, this part, and finally I open. This is stenotic, and this Terumo G. This open, and the stent is open. This is a control with the in the right side with the papilline. Also, I complete the treatment with angioplastia to have more flow. This is the final control in right side. This is the CT scanner reconstruction. 1 week later, the patient bled. But this blood is distance, no proximal to the aneurysm, is in oval center. What is the origin of this blood? Antiaggregation, not because the patient is treated by antiaggregation 2 years before. Difficult procedure, manipulation possible, endo leak, or increase it in flow, irreperfusion syndrome. Some paper from Japanese doctor present the same bleeding in patient with Church-Strauss syndrome. And I think is recommend treating the patient with steroid in this case. But now I'd like to present some reflection of my experience. In giant carotid aneurysm, the 90 to 91, in 19 to 2001, I treated 95 patients. One group, the first group, 45 patients, 90 to 96, treated only with balloon, occlusion balloon test, and this patient, 96 to 37, occlusion balloon test and other technique. Totally, 82 patients treated with occlusion balloon parent vessel, 5 remediating, 1 stent, 1 stent coil, 1 stent onyx, total 95. This is the 90 to 2001. The complication, the 1996, only with the balloon technique, I have 1 rupture of the siphon of aneurysm with exit, and 3 neurological deficit secondary to thrombus, migration thrombus in sac. 2000 and 2006, 1 stent delay rupture 1 week later, after 1 stent, and 1 rupture with onyx. The patient is very bad situation and dead. Two neurological deficit. This is example to test with a sacrifice with balloon test, the giant aneurysm, AP view, lateral view, balloon. I prefer to place in this period, I prefer to place before, no trapping, only before. Because you are the technique of trapping, you are sometimes you don't have the space to place in this part balloon. Only you put here, you are thrombus. I complete no a second balloon. I complete the embolization with glued the carotid in this part. Another example is difficult to navigate to balloon.
Hello, Louis. Louis may have fallen off.
Okay, yeah.
Okay, go ahead, Louis.
Okay, sorry. Yes. Okay, this is the control in the right carotid and the vertebra. CT angio. Another example with the trigeminal artery, persistent embryonary artery, the balloon placed here. This is a complex case in pediatric population. It's fusiform giant aneurysm. The patient is treated before by 2 bypass, external and internal. The AP view in the left carotid, this carotid, by communicant artery also perform the vascularization to the right side because the right carotid artery finishing only in the ophthalmic, don't have this portion. I decided to treat it with test balloon. In the left carotid. This is the right carotid, the finishing only in the ophthalmic artery and some anastomosis in lateral trunk. This is the right. After the sacrifice of the distal part of aneurysm, the patient developed 24 hours later hemiparesia and dysphasia, and then recovery 1 year later, progressive recovery. This is a thrombus. This is a control 5 years later. But the patient developed a small aneurysm in basilar artery. Probably it's a vasculitis. And patient, few years later, dead by bleeding because this aneurysm is ruptured. This is a case is rupture with a stent, only with a stent. Treated before this aneurysm with coiling, but this second aneurysm, I placed one balloon expandable stent. And this is the stent. This is the stent. 1 week later, the patient come to the hospital with massive bleeding, probably secondary to manipulation, too difficult to navigate to this stent. This is in this period of time. Other stent, a small flow, a small neck, sorry, high flow. I put the stent. After a stent, decrease the flow in sac. Some part of the stent, this part, is still in one lenticulostriate artery. This is after embolization. This is 1 month later. AP view, the stent now still compact because it's too short, going here. After embolization, no deficit. 1 month later, it's open. Evolution, 1 month later, are totally occluded. This is the stent in this part, a totally occlusion. Lucky. Also, I treated the 2000 and 2006 many cases with onyx, 28 cases of giant aneurysm. The technique is more complex. Some anatomic limitation. The saline test is critical and difficult, but is the excellent result long term. Why I don't use anymore this? Because the technique is complex. One example with onyx. In acute phase, this is the point of rupture. This is the onyx. And this is the cast of onyx without stent. Sometimes this patient is treated in another center with coils. This is the regrowth aneurysm, remnant neck. In few months growth. And then I treat with onyx. And the occlusion is stable. Complication of onyx. One rupture during embolization but unsealing, and one migration, the onyx after 2 months later, 2 months later. This is a case, the migration is a very particular anatomy of this patient. Look, the middle cerebral artery and anterior cerebral artery have intracavernous dysplastic aneurysm. I decided to treat it with onyx and I stopped here. After embolization, this is the situation. Some onyx still in the wall, but 2 months later, the patient comes to the control, the aneurysm growth, and the onyx, some part of the onyx migrates. In this situation, I decide to place one stent before remove with a basket, remove some part of onyx in the middle cerebral artery, and also place one stent, carotid stent, to replace the cast of onyx. This is the control, and this is the cast. This is a rupture aneurysm, and this is the onyx, very quickly. And another case of onyx, I think is not. When I use the onyx, it's important to put some cast of onyx around the carotid. Sometimes you are stenosis, previous stenosis in the aneurysm. No, in the sac, also when the artery going to in the foramen carotid. The sonics, in the sonics. Okay, I like to present some case and some difficult. Thank you for your attention.
Okay, Louis, thank you very much. Okay, we have any comments or questions from the panel for Louis?
Or for Bai.
Or for Dr. Bai, correct?
Yeah. And from your lecture, dear Louis, from your lecture, I get two cases very impressive. One is intracranial aneurysm. You treat it with a balloon-mounted stent. I don't know whether it's a curved stent or bare stent. Why you use balloon-mounted? As we know, it's very hard to use a balloon-mounted stent to get a good vessel wall absorption. So
Because
this is one case. The other one is I don't think the giant intracranial aneurysm treated with onyx can benefit neither mass effect or endocellularization. That's my
Yes, no, but the case I present is the old case.
Okay.
This is the old case. I like to present what is the situation in the past 20 years. No, at the moment it's different. But I don't know, understand why the onyx is total excluded in the treatment. I think it's only the political industry topic, is not medical, because I treated one or two cases with flow diverter and onyx, and it's good. It's good. You jail in, and it's possible not use the onyx, not use the coil, use the onyx. And wow. It's better. It's better because with the technical use, the onyx use the balloon. Normally use the balloon, but if you have inside one stent or flow diverter, it's better the sealing to the aneurysm. It's better. It's not easy. But now it's not. I don't have any more Onyx 5000. But in my opinion, it's possible. It's possible to use the Onyx 18, but it's not legal. This is the critical point. I am in Europe. Maybe Pedro in South America, or another doctor, Anil Karakpulkar in India. It's possible. You are possibility to treat the flow diverter with onyx. In Europe, is not possible.
I think Pedro has a comment, Louis.
Mm-hmm.
Unmute yourself, Pedro. You're muted, Pedro.
It's missing.
Okay, may I comment?
Sure,
may
go
I
ahead.
comment?
Sure.
Okay, so I have seen everything to treat giant aneurysms. I began before microneedle surgery. We were occluding the carotid artery in the neck with Crutchfield or Selden screws. And actually, the late outcome of these patients was rather good. We have published also long-term follow-up. So you think that the occlusion, proximal occlusion is very dangerous, but it proved that those who survived, they did very well with their 3 other arteries. One special case was in the 1974 4, I occluded carotid artery in a young stewardess with giant carotid aneurysm, and she died in front of my eyes. So quite suddenly when I closed the screw and they opened, so she died in few moments in front of me. It was extremely impressive. Then came microsurgery, direct clipping, and bypasses came, and then came the coiling and stents. You have tried everything, and the complication might be less, but still remain. So these different methods have been tried. I still think that proximal occlusion is very safe and the cheapest method, because what happens now, those who have a lot of money, they can get stents and coils, but those who are poor, they must have other kind of treatments in the whole world. This is how the situation is. So it is unfair, but this is the reality. So those stents and several stents and coils inside the giant aneurysm, they are the price of a house.
Mhm.
So this is difficult for many people, and you cannot manage. And it's all what we are speaking with the stenting and coils. This is first world therapy, so not accessible for all the patients. So we have to think also for more cheaper solutions. So bypass, proximal occlusion might be very good solution to treat these difficult cases. So this was what I'm thinking when listening to these lectures and my experience. Thank you.
Yeah,
Okay,
thank you.
I think
Pedro.
Pedro had a comment. Go ahead, Pedro.
Finally,
Yeah.
I really enjoy, guys, your talks, and I think we always are learning. Luis tried to summarize the history a little bit with his presentation. I think, as Professor Hermismeni pointed out, I think the option of proximal occlusion is good. I mean, we have practiced in that many years ago, and I still sometimes once in a while we do that. Things are evolved. Of course, the cost is something that we have to keep on mind in every single country, especially in Latin America and other countries. We keep that, but also the cost, the radiation that we also give to the patient. There are so many variables that the timing. I mean, one thing is try to put several coils and stents and have a length procedure for the patient and also for the people, a lot of radiation. Another thing is just a short procedure with flow diverter or even shorter with or less complicated with bypass. So we have to adapt, and everyone is living in different parts of the world and have different approaches. I would like to take advantage of that and ask Professor Bai about the Chinese flow diverter. In this part of the world, we don't have the privilege to use it. So what are the main difference in your daily choice? Why are you choosing through bridge or you choosing pipeline in China? There is any advantage choosing one or another one? Can you tell us, because we don't have experience with through bridge? This is one. Second, one thing that we learned with Luis and many years in the field, the anti-platelet regime is something very important. I would like to know your regime in China. Are you using dual? Are you testing every single patient? Are you still using clopidogrel? So there is a couple of questions that I would like to ask you, Bai.
Thank you, Professor Lilik. Thanks for your question. One question is, just like Professor Hermismeni said, the flow diverter. Yes, maybe due to culture issues, most of patients they have extreme fear for open surgery. Even they are in a poor financial situation, they can still accept the flow diverter.
Professor Lilik?
You went on mute there.
Yeah, Lilik?
You're
Professor
on.
Lilik? Yeah, I'm Bing Xu from Shanghai Huashan Hospital. Actually, I can ask your answer your question about the tube bridge. It's cheaper than the pipeline in Chinese market. It's only maybe 2/3 of the price of the pipeline. And the Chinese health insurance can cover the more percentage. It's covered around 70% of the price of the tube bridge, and for maybe 50% of the pipeline. So it's much cheaper for the patient to select the tube bridge. And technically, the tube bridge, I think the one main advantage of the tube bridge deployment is it can retrieve much easier than the pipeline. When you deploy the first part of the stent, yeah. So it's quite easy to retrieve and deploy.
And the tube bridge is only covered by insurance in Shanghai district. For other area, patients have to pay much of that. So some physicians say they are tube bridge like a girl, and the pipeline it works like a boy. So maybe tube bridge is much more flexible, I think.
Yes.
Okay. Okay. Go ahead. Any closing comments or questions for the panel?
Yes. The catheter to deploy the tube bridge is a special catheter with this stent, China stent, or your standard catheter? What is the catheter, the super catheter, to navigate to the tube bridge?
Yeah, it's specialized. It's a specific homemade microcatheter to deliver the stent.
Okay.
Okay, very good. Okay, I guess we'll wrap it up. Thanks everyone for participating, and especially to Ben for translating into Chinese. Did it go well, Ben? The translation?
Yeah. Now the audience is almost 4,000, I think.
Oh, that's excellent. And we're achieving the desire of Yuha to reach the Chinese surgery community. And this is great. Okay, Louis, what do you have? Do you have anything planned for 2 weeks from now?
Yes, I think I discussed with Yuha or with Bean or Pedro, whatever you want. I like to discuss also with the aneurysm in the middle cerebral artery.
Okay.
Complex middle cerebral artery aneurysm.
Oh, very good. Okay, we'll get that together and we'll see you in 2 weeks. Okay, thanks everybody.
Thank you, everybody.
Okay, thank you.
Thank you all.
Thank you.
Thank you all.
Bye-bye.
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 Bye.
Very good. Okay. Okay, it went well. So how you been, Yuha?
I'm okay.
Yeah.
I'm sorry I cannot give permission for the tomorrow's PhD. This is Helsinki University thing.
Yeah, I'll write to Johan. He wrote to me. I'll write to him.
Okay, then it's okay.
Is that something that's usually filmed, or is it a private private meeting mostly?
Actually, this very old tradition, so it might be interesting to see in the whole world.
Oh, great. I would love to do that. I'll ask him.
Okay.
Okay, thanks,
Ask
you.
him. Okay.
Okay.
Bye-bye. All the
Bye-bye.
best.
I'm just going to hang out here.
Yeah.
Does anybody want to talk to Juha? This is a great chance, man. Anybody out there?
Okay, next time. Next time.
Next time. Okay.
Okay, bye-bye.
Okay, bye-bye. Dr. Zayden, how are you? Are you still there, Joanna? You gone? I guess. Okay. People go on with their lives.